Good afternoon and welcome to the Alliance for Home Health Quality and Innovation's webinar on Changing Care for the Frail Elderly, Community-Based Care, Long-Term Care, and ACOs. My name is Teresa Lee and I'm Executive Director of the Alliance for Home Health Quality and Innovation. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients and the entire U.S. healthcare system. Today's webinar is part of the Alliance's Innovation Perspectives Speaker Series. The Innovation Perspectives webinars seek to provide diverse perspectives on innovative healthcare delivery models and identifying home health care's role in them. The webinar today will focus on innovative models used to care specifically for the frail elderly in communities. We're fortunate today to have as our guest speaker Dr. Joanne Lynn of the Altarum Institute's Center for Elder Care and Advanced Illness. Joanne Lynn is a physician, geriatrician, hospice physician, health services researcher, quality improvement advisor, and policy advocate who has focused upon sharing American healthcare so that every person can count on living comfortably and meaningfully through the period of serious illness and disability in the last years of life at a sustainable cost to the community. She now leads the Center on Elder Care and Advanced Illness for the Altarum Institute. Dr. Lynn recently authored an opinion piece published on November 13, 2013, in the Journal of the American Medical Association on reliable and sustainable comprehensive care for frail elderly people. We're so pleased today to have her speak to us as a thought leader on matters related to aging and elder care. Just a few housekeeping notes before we get started and I turn it over to Dr. Lynn. First, she will speak for approximately 40 minutes and will leave the last 15 minutes to answer questions. Please note that this is a webinar and we control the slides on our end, so please don't be surprised if you're unable to flip ahead. Second, your lines will be on mute. You can submit questions to be answered during the Q&A period through the Fuse webinar software on your computers or other devices. There should be an in-meeting chat box that will show up and you can submit questions via that box. Finally, we will be posting the slides on the website after this webinar, and we are also recording the webinar and will post the webinar on our website for playback. Without further ado, I'd like to turn this over to Dr. Lynn for her presentation today.
Hi, I'm so glad to be with you. I think you'll find this to be intriguing and not only to be salutary to home care, and that a lot of what I'm looking to do is to move more care to the home, but also changes home care a lot in terms of what we think we're doing and what the scope of our endeavor is. So I'll be very interested to get your feedback. Feel free to put things into the chat as we go along, and we will have time at the end. So Teresa, do you control this and move it forward?
Yes, you can just say next slide when you're ready to go to the next slide.
Yep, go ahead. So, it's no surprise to you all that what we want in old age is something like this image with having relationships and reasonably good health, and what we often get is the next slide, which, is the disability, the being in a medical setting, and much of what has made old age really miserable is avoidable, and that's what we're after. First, just a little about the calamity coming at us. Go ahead to the next slide. The change in population already, this is up to 2003, from 1950 to 2003, and the percentage change by age group. It's really hard to get people to understand just how dramatically we have changed the aging spectrum in the United States. You'll notice that by real numbers, we have fewer people under 15. We actually have fewer people all the way up to 35. But look what's happened to past 75 and past 85. And that's before the boomers hit. So when the boomers really hit their stride here, we are going to have these proportions almost double by 2030. So, if you have kids that are looking for a career, I'd suggest maybe undertaker. There are going to be a lot of us coming to the end of life at the same time. So, there will be 1,000 adjustments the society needs to make, and we haven't even really started thinking them through. Go ahead to the next slide. One of the most important is the economics of this. This is an unusual way to present the data, but bear with me a minute. The numbers across the bottom are ages. So this is 0 to 90. The data past 90 is too thin to graph. And how much people at these ages are spending. So the gray at the bottom is sort of everything that the public spends, and the red is everything that individuals spend. And as you work your way up, you'll see that the yellow bar there is private spending on healthcare. And that little tiny bar at the top on the 1960 graph is public spending on healthcare. And then look what happened by 1981 in terms of how much both private and public spending had increased. And then look at 2007. This is before the crash. The crash has affected most other expenditures, but not public expenditures on health. And we are due to almost double the expenditures past 65 within the next 15 years. So those of you who are reading ahead may wonder what the one line is there. The one line is the peak productivity of people in the labor force between ages 30 and 49, which is traditionally your peak productive years. So you'll see that the economic engine can barely support what was happening in 2007, and you can see how crippling it will be to allow this growth to continue unfettered. So go ahead to the next slide. How are we going to keep from going off the cliff? Well, we have a vision of how this could happen, and I'm here to try to persuade all of you that it would be a pretty clever way to move ahead. So go on to the next slide. The MediCaring program aims to assure that we can count on living comfortably and meaningfully, but that the cost will be sustainable through the period of frailty that now affects most of us in our last years. And that period of frailty almost didn't exist in 1960. It was very uncommon that people lived that long. You could see that in the numbers of people who were in very old age. So let me tell you what goes into that. Go to the next slide. These are the elements that we believe are essential. The first is you have to see this period of disability at the end of life, the last few years of life on average, and lack of reserve as having different priorities than you had most of the rest of your life. So people who are in their 50s might very much want almost anything that would return them to good health. Once that's really off the table and you're going to be living with various disabilities and problems, priorities tend to shift. People want to live comfortably. They want to live in relationship to others. They want to have the opportunity to do things that are still meaningful and fun. And the priorities become much more living well with the burdens that you have. Once you're in that group, you really need some team to understand you well and to develop a good care plan. And that care plan is not just that the wound care needs done or that the medications need administered, but it's more how the person's going to live. What services do they need to have in order to do reasonably well? Sometimes it's housing or transportation that's most important. And then the third thing is you need the services. And those services need to be what we can now call geriatricized. We need people to have services that are in their home in general, that they're very supportive, that they're really helping people do the things that are most important to them. And therefore you can't have a whole lot of doctors in silos and the only reason a person ever gets out is to go see their doctor. You've got to broaden the scope, which is the fourth endeavor, and this is it really must include the social services. And then fifth, we believe that there has to be a layer of local monitoring and management, that you can't actually make a system this complicated work from the state capital in Baltimore. You're going to have to get down and dirty in the behaviors of each city, each county, and have a layer that notices whether you're oversupplied or undersupplied in some arena, and is able to shift some resources to address those things. And then, of course, we need the will to make changes. So we need to have people angry enough to move ahead. So go ahead to the next slide. I do hope you'll chat in if anything that I'm going through is just too fast or really needed an explanation. I can pause and address those chat comments as we go. People get quite hung up on how you're going to find the frail elderly. There are all kinds of ways to do it, but one of the most simple and direct is to say the person is elderly in the sense that they're at least over 65, and they either have more than one activity of daily living deficit, so they're requiring the constant attendance of somebody else for that reason, or because they have such poor judgment that they really need someone to be in their environment all the time, or they have a condition that's really likely to get them there within the next year or two. So somebody who isn't quite yet this disabled with ALS or with Parkinson's, you might well include them, unless the patient opted out. And then, of course, you would not do that. But also people who are over 85 just have so little reserve that the first thing that comes along that causes serious problems is likely to generate a cascade of problems. So I think at that point, if somebody is really still quite healthy and functioning well, but they just want a care system that can support them well and that is makes sense, then they should be able to opt into it. So those are our sort of working definitions. Different programs, different communities do it differently, and I think the big point is that there's so much overlap that it doesn't matter much. It's important to get started. So go ahead to the next slide. Then you need a individualized care plan. The care plan has to reflect the person's real situation, their medical situation, their nursing situation, their family situation, their finances, their housing, and be a workable plan that reflects the patient and family's priorities. So somebody who is dedicated to making sure that their adult retarded son is taken care of is in a very different position than someone who is living entirely alone and is just scared of something going wrong and nobody being around. People have very different priorities as they come to this part of life. So go to the next slide. I would say that the good care plan is the keystone. Those of you who've ever been in Pennsylvania will know all about keystones. When you build a bridge, you build a very strong bridge with a keystone. But without the keystone, the whole thing crumbles. And that care plan is really the heart of the matter. And if you don't build a care plan and you just sort of do things in a reactive way, you end up leaving the patient in danger of multiple errors and constantly afraid of what might happen next. A good care plan makes it all make sense. So go to the next slide. One of the things we don't do with care plans, even when we have them, is to evaluate them. So for individuals, we need to know that people in this phase of life have care plans. There's a presence of a care plan, that it's known by everybody who needs to know it, that the physical therapist and the nephrologist and the primary care doctor and the home care agency are all seeing the same care plan, and that it is in fact implemented, and it's implemented across settings. So the care plan comes into the hospital with the patient, gets modified in whatever way it needs to be, and then goes out with the patient. In some countries now, you cannot discharge a patient without the outpatient coordinator knowing that the patient's ready for discharge and agreeing to the care plan. So that's the kind of thing I think we would start seeing if we got serious about this, or when we get serious about it. We need to measure whether everybody is satisfied with the process, the patient, the family, the care team feels like everything was heard and that there was a real chance to develop the best possible practical care plan. You need the patient or client report that the care plan is helping to pursue what is most important to this patient. So if what's most important to this patient is going fishing, then let's figure out how to get the oxygen to the riverbank. It's about what it is that's important to patients, and they have to be in the driver's seat. I think it also matters to get their report of confidence that the care plan will work and that It will work in the presence of threats, of getting a fever, of having the caregiver not show up, of how the things that happen that foul things up. And then I think the real measure, the sort of gold star in the measurement system, is did the person get the life that they most wanted, given what the situation was? Did they get their values, their highest goals pursued well? And we have not yet learned to measure this, but I think we really must. We have to start measuring in ways that the individuals can turn out differently. And then we also need to evaluate care plans for how systems are working. How well are individuals involved in care teams working out the care plan? Are we getting feedback to the upstream providers? So if a care plan that was put in place by a SNF is inadequate to a home care agency, is the SNF learning that that's the case and able to do some self-correcting processes? And then there's also the possibility of using care plans to manage the service supply, and we'll come back to that. Go ahead. So in thinking about care plans, we often think in terms of a person facing a choice and figuring out which one serves them best. But I think that we have a more dynamic model in mind when we're thinking about care plans in this population. People come into the system with values that they're able to say, what matters to me is this, and it doesn't matter to me so much those other things. And as they work through toward a plan, they will articulate those things as goals. So, one of my goals is to continue to play with my grandchildren just as long as I possibly can, or not to be a threat to them because of the C. difficile I was sent to the from the hospital with. And so you build a plan, and in the process of building the plan, you actually uncover some further values, and you reorder them. The patient says, I said that this was terribly important, but actually it's this other thing that's more important. So there's a feedback loop back to articulated values. And likewise, as you implement the plan, there's a feedback loop back to the plan. So, you implement the plan and you discover this person has a side effect, or something's not available that you thought would be. And so you have to modify the plan. But the trick here is that the outcome is the life lived, and the outcome is how well that life lived is serving the patient's goals. So the evaluation of quality of a care plan has to measure the outcome back against those values. So we need to develop the mechanisms that allow this evaluation to happen routinely so that we can regularly see the degree to which we are serving patients well. Next slide. People get all hung up on advanced care plans. Well, once you start doing serious care planning, advanced care plans just become part of care planning. Anybody this old, this frail, is going to be noticing that death is in store at some point. And of course you consider the lifespan and how it is you will die as part of care planning. And where you can do so, you include emergency plans like the POLST, so that people who don't have enough time to really know the record will know whether you want to be intubated, whether you want to be transported to the hospital, those sorts of things. You certainly need to designate a surrogate decision maker anytime you can when there's somebody who's willing to take on the role of making decisions for the patient. You need to document the advanced care plan right in with the with the rest of the care plan. It's just a part of it. And then you need to update it and provide feedback on it, just like you do for all the rest of the care plan. So this sort of perspective gets it out of the Sarah Palin bizarre, death panel kind of stupidity, and instead says, no, actually, everybody cares about their future, and they, in general, want to have a say in how they live it. And let's give them the opportunity to do so in documenting it in a good care plan. Next slide. I won't spend very much time on this because I think this is probably pretty familiar to this audience. But medical care has become organized in a way that is actually harmful to the well-being of frail elderly people. And the kinds of things that need to be reintroduced or introduced anew are things like continuity, 24/7, where you can make a promise right from now to the end of life, enabling the patient and family to manage their own issues, and really respecting those other caregivers. The family still provides more than half of the care for disabled elderly. We're really going to have to honor the family. I'm still stunned that most hospitals don't even record who the family caregiver is. I know home care does, but not usually hospitals. We have to pay attention to how much we burden people by saying they have to do this with their diet and that with their pills and this other thing with their exercise. And by the time they follow all of our instructions, they don't have time for prayer. We need to move services to the home. We need to prevent falls. Falls are 1/10 of all hospitalizations. Errors, about half of everybody who goes from a hospital to a next setting of care has a substantial error in their transition. That's just crazy. We need to respect that as long as possible, relationships and activities matter. People really care about what they're able to do. And then, of course, there's the challenge of dementia, which is so perplexing to all of us. How do we understand the experience of dementia and what counts as doing a very good job? And at least for the moment, we need the care teams to help families endure. So I think that there's a chunk of things to be done to really fix how medical care is given. But there's another piece. Next slide. And that is to really pay attention to these social services. Everybody's used to the bottom half of this slide, this part with the dark bars, showing that the United States healthcare system is on track to spend more than anybody else ever is thought to be appropriate of our GDP on medical care. At the time of this slide, it was 20%, but it's already up to 17.7 last time I saw. What's really intriguing, though, is that when you add social services, we are really thin. Go to the next slide. So the proportion of, if you put the health service over social services, we have only 80% as much spent on social services as on health care. And most other countries are hitting about twice as much. So in most developed countries, these are all the OECD developed countries, you would have a program that would be assuring housing. You would be assuring that people had transportation. You would be assuring that they had nutrition, as those sorts of things. I mean, there would be a housing program for elderly people. We instead fund the medical care side and not the social services side. So go to the next slide. So frail elders really need a whole lot of support on that social services side. And we have it funded as a safety net. We don't particularly measure it. There are lots and lots of programs. We allow gaps to occur. So some state may have a respite care program and it can serve 1,000 people for 2 years. At the end of 2 years, it just goes away. On the other hand, medical services are all open-ended and can go on forever. I can, with a stroke of my pen, order up a $100,000 drug, but I can't order Meals on Wheels if it's not available, if there's a waiting list. I can't order a caregiver if the caregiver gets sick. The way we measure quality in medical services is actually inappropriate. So we keep saying, well, we want the hemoglobin A1C to be under 7. Well, for most of these frail people, that's actually the wrong goal. They should be allowed to be 8s and 9s because hypoglycemia is so hazardous for them. So we end up with all this wasteful, unmanaged, or unreliable, inappropriate services, and no one integrating them. So we don't even have a place to have the argument about what it is that would really make sense. So we need to have some sort of an integrator, and we contend that a big part of that integration needs to happen at the local level. So next slide. So frail elders are really tied to where they live. You should hear Senator Rockefeller talk about how frustrating it was not to be able to get what his mother needed as she was living at home with Alzheimer's. And he came to the stark realization that it didn't matter how much money you had. If the community didn't have certain kinds of services, they simply weren't available to you. So frail elders are really tied to where they live. You've got to have that spoon feeding 3 or 4 times a day right where you live. You've got to have the bed bath where you live. You can't go somewhere else for a second opinion. Local leadership is able to respond to facts about their community. Localities can engender and use some off-budget services, especially volunteers, people who are willing to help out a neighbor, people who are willing to help out just because their church is in this neighborhood. Localities can address housing issues. They can address transportation issues that the medical care system mostly can't. They can address employer issues for caregivers, so caregivers can have some flexible time. And local management is politically plausible now when more functions at the state and federal level are really pretty unlikely. This highlights one substantial issue, next slide, which is that we have thought that having whole lots of different providers serving any one area is a really nifty thing. But once you start having to move services to where people live, you leave a lot of money on the table if you are not geographically concentrated. So if you have 25 home care agencies that can serve a particular apartment building, and you have 15 people who need in-home services, you could have 15 different agencies coming in, each of which will have some kind of a minimum stay, each of which will tolerate having their aide, twiddling her thumbs, metaphorically at least, for a chunk of time, and having the transportation problems of getting to the next person. If instead you had one agency, or at most two in there, you could put a relatively straightforward, smaller number of people who could move around, and you end up saving about half of the home care dollar. So we aren't going to be able to ignore that for very long. We're going to have to figure out how we can allow some geographic concentration. And of course, we have to address the risks of monopolies, that they'll drive up the cost and cut the quality. But I think as a public watchdog, we can probably manage to watch over that. So if you are at least agreeing that possibly we would want some kind of a local entity, what would that local monitor and manager need? Next slide. One of the first things they need is some way to know how well the community is doing. We've been working some on that, and I just want to show you a couple examples. Go ahead. Next slide. This is readmissions in all of Cincinnati over time, and so you can see that those sorts of things you could readily put on a graph and monitor. Next slide. Here we're asking a patient on whatever day they think to do it or whatever day they're seeing somebody, how well are we doing in pursuing what's most important for you? Think about your goals in the rest of your life. How well are we supporting your support of your goals? Give us a score from 0 to 4. And 0 would be we aren't doing anything appropriate or helpful. And 4 would be, it's a thorough delight. Everything that I most hope for is there. So, you would graph it over time, calculate the area under the curve, provide it as a ratio. The area under the curve here is half of the ideal, and you would be trying to improve that score. So that's the kind of patient self-report that I think is really going to matter in the future. Next slide. Been working with Jönköping in Sweden, and they have a public dashboard of the care of the elderly that I'm only showing you a couple of the slides from it here, and obviously it's better if you could read it in Swedish. But here's the one slide is all the different municipalities by counties. So there are 3 counties, one big lake, and a whole bunch of municipalities. And here you're comparing different municipalities across various measures that matter to them. So you can see, for example, the bottom right one is antipsychotic use. And you can see that some communities have a very low rate and some have much higher. Next slide. And you can also graph almost any of these things, not only by municipality, but across time. So here's the pressure ulcer rate for people living in what they call service homes. And then the pressure ulcer risk assessment in service homes, and then down at the bottom, the different municipalities and how they're performing. So this kind of a dashboard could be done on a geographic basis, and you could know whether, I live in Washington, D.C., is Washington, D.C. doing better or worse on pressure ulcers than it was 3 years ago? It's a very different way of thinking about performance, that we're all interrelated and that we are all contributing to this sort of outcome. Next slide. We also can use those care plans to build a service production system as if we were managing a factory and producing services that match the needs of the client population. And this is a model we've built for Washington, D.C., and you may take issue with any of the particular data points in it, but the point here is that you could start thinking about the service production system for a community and managing it and knowing whether you have too much or too little of any particular thing. So go ahead and show the next slide. And here's an estimate of how many frail elders there are in Washington, D.C. We said 6,000 die each year, about 5,000 in old age. Half of those die of some single overwhelming illness, and the other half have multifactorial frailty. And self-care disability will last an average of 2 years. It's really almost 3 years now, but we're working with 2. So at any one time, you have 2,500 people who are going through their 2 years. So you have 5,000 frail adults over 65 years of age who are going to be in need of frailty supportive services. Next slide. So you have your 5,000 frail elders, and we were estimating that and there's a lot that goes behind this, but this is sort of the summary, 1,000 people will need nursing homes. They have needs that can't be met in the community given their particular situation. And you have 4,000 people who are living in the community, and 2,500 of them are being provided care by their family. And probably we need to cycle back and figure out how we're going to support those families. But for the moment, focus on those 1,500 with community-provided care. They're going to need attendance around the clock and 3 hours of direct services daily on average. Next slide. So you can estimate things like, how about primary care providers, doctors, nurse practitioners, and so forth. And you can do this for each kind of service provision. So we'll say you have 4,000 people living with serious frailty in the community. They need a routine visit about every 4 months and an urgent visit at about the same rate. So they need 6 home visits a year. That's 4,000 people times 6 visits is 24,000 visits. Then you say, okay, so what do we need to provide that? And a primary care provider can see about 10 visits a day, 240 days a year. The community will need 10 full-time primary care physicians and 10 full-time assistants and drivers. And they'll need to have 24/7 coverage for out-of-hours issues, and those can be done by those primary care providers or by a little bit more added in. But I think it's quite eye-opening to realize you could take care of everybody who needs home care at home in Washington, D.C. with 10 doctors. Kind of neat. Go to the next one. And so as you work this through, this is just sort of a summary. We estimate that we need 1,500 direct care workers in the community and 500 in nursing homes. We need 100 nurses and 500 people in the community. You can see the kinds of estimates we're coming up with here. I'm not saying these are the right estimates, and some of you may want to substitute some better estimates out of your experience. I'd love to see them. But the point here is that you could think about the service production system for a community as a service production system for a community and start comparing whether you have more or less than a community that's doing as good a job or better. You could compare over time. You can geomap services. And you can also take the care plans and directly map them to this. So instead of building this sort of a service production system out of the literature, as I've done here, if I had 5,000 care plans for Washington, D.C. frail elders, I could geomap every service needed. I could know whether we have too many or too few of almost anything, and could raise the question among the providers. If we have twice as many hospital beds as we really need, what should we do about that? Are we getting supply-induced utilization? Should we deliberately try to cut that back some? What would we need to do that? So it gives you a tool to actually step in and manage a community as to its service production. Next slide. So the local manager will need those sorts of tools, but they'll also need some other things. Certainly in the United States at this time, we do not have an entity that can speak for the community readily. So we're going to need to build coalitions. We're going to need to build governance. We're going to need to build values so that local residents trust this sort of an endeavor. Funding, we believe, can come from shared savings, and I'll tell you more about that in a minute. We need the entity providing the management to have some authority. And I believe at this point in time, with the coming doubling of elderly people, we must have a commitment to efficiency as well as to quality. Remember that slide about the macroeconomics. We cannot just keep drawing from the economic engine. We are already really cutting into the opportunity to educate children or to build bridges or anything else that matters. So efficiency is going to have to be part of the scheme. Next slide. So frail elderly people are going to need some new spending. It's going to be on the social support system, housing, nutrition, personal care, caregiver training, and then, of course, some new drugs and treatments. So where can we draw that from? Well, let me tell you a little parable. Next slide. This is my mother. She's 92 years old now. When she was 90, she crushed a vertebra. She went to the emergency room. She told the doctor that she had crushed T12. She's a radiologist. And he said, "Oh, no, you haven't. You have a urinary tract infection." The next ER doctor was more appropriate and correctly diagnosed the crushed T12. And she went home with every imaging study known to man, a corset that would have fit Magic Johnson. She ended up, next slide, spending about $10,000 of Medicare money, all of which would have looked okay on all of our existing quality measures. Her orthopedist was desperate to have her do a vertebuloplasty, which has to be the only procedure I know of that has had 2 sham randomized controlled trials where people agree to have their procedure and not know whether it was a real one or just a sham, and then be followed for what happens. And the outcome is that it makes no difference at all, except that people who've had vertebuloplasty fracture the vertebra above and below at roughly twice the rate that other people do. So it's actually a harmful procedure. Nevertheless, Medicare pays for it, would have paid about $20,000 to have it done. What is it that she really needed? And I know in this audience there are lots of people out there who know right off what she needed. She needed good home care. She needed a good home care nurse to come in and make sure she was getting adequate pain relief, that she was getting mobilized, that she wasn't getting terribly constipated, that as soon as she could move around, she was moved around, and gotten back on her feet, try to keep the muscles from getting too dystrophic, too weak while she's on bed rest. And in 6 weeks, she would be back to nearly where she had been, maybe having lost a little ground. But that, of course, is in general not available. So getting that kind of service, and especially getting it straight out of the emergency room, is really tough. So we have gone about building the model and estimating how much you could save in medical care in Medicare. Next slide. So we've estimated the frail as being 10% of the population 65 and over in a geographic area. And we've estimated the per person per month costs, except for family caregiving. So I must acknowledge that we are not counting family caregiving. And we've used Medicare's HRR, that's a hospital referral region, and county data, which is now a public use file, to get the aggregate costs in Medicare, the population, and the utilization of services in the present time. And then we used the literature to estimate long-term care costs and small ancillary costs. And then we estimated realistic goals of reducing medical care, building on all those wonderful reports from PACE and guided care and the SHMOs and the special needs plans and hospital at home, and on and on. They're just all sorts of small studies, usually just a couple hundred people. And then we used generally about half of the maximal effect. So if the VA has reported that they were able to reduce hospitalization by 60%, we only used 25%. We were pretty conservative, as to what you could achieve. Next slide. And it turns out that in 4 geographic communities with 15,000 frail elderly people as the steady caseload, you could, by working on all these fronts, save $23 million in the first 3 years. Now, there's some startup costs. You'll see in year 1 that you're in the negatives, and in year 2, you're just sort of breaking into the positives. But by year 3, you are really saving a lot of money. And if you want to see more about these financial estimates, we have a little YouTube up that shows some of the spreadsheets, so you can check it out for yourself. Next slide. So we know you could really save a lot of money in medical care, but how would you ever have anybody do that? Well, what we've proposed is in the 3rd year, convert to a special purpose accountable care organization that is, contrary to the present accountable care organizations, allowed to enroll only frail elderly people, only those who live in a particular area, and you'll measure the population well-being and the population's cost, the enrollee experience, have plans of care online, make sure they're used, have feedback upstream, and use the plans of care to guide the production system. You build a dashboard like I was showing you from Sweden, and you would have governance and authority in some local endeavor. It can be a voluntary coalition, it can be a strong lead organization that's contracting with everybody, or a local government entity. So our aim is to basically substantially reduce the overuse of costly services in the medical care arena, use that to support both the social services that people need and the monitoring and management that needs to be done at a local level. Next slide. So just to reprise, we aim to have people notice the frail elderly cohort and be willing to do things differently, customize the services, generate those excellent patient-centered care plans that really reflect the person's preferences among alternative futures, adapt medical care, geriatricize what doctors do, include long-term services and supports, and develop a local layer of monitoring and management. And we need to motivate people to care to do this. And I think the fear and frustration needs to be channeled into the will to change. So next slide. Buckminster Fuller's wonderful line, you can't just fight the existing reality, you have to build a model that makes the existing model obsolete. And I think we've got it here. And if you are in a community that might want to do this, please be in touch. Next slide. These will all be posted. We've put here a number of resources that you may find useful. Feel free to poke around in them and see if any of them are helpful to you. And you can do the next slide, and we'll shift to taking comments and questions. So just sort of faces of the frail. Oh, and here we have put the questions into the chat box, and there's where the slides will be. So I hope you have some comments. Anybody have a community want to try this out? Or think it couldn't possibly work, and tell me why.
Thank you so much, Joanne. Gosh, what a great presentation. And I really think that the way you think about these issues is visionary, and I hope it's sort of an achievable future that you've been talking about. So let me go ahead. I don't see any questions yet. I'm going to go ahead and ask you some questions of my own, just based on what I've heard you say. You mentioned a few different programs that might be sort of promising or interesting directionally, and it's what you maybe base some of your cost savings analysis on. I think you mentioned PACE and guided care, schmoes, hospital at home. I'm wondering if you can talk a little bit about how your model differs, in terms of the way you're thinking of it compared to those other types of programs.
Well, it has an awful lot of alliance with the insights that lead to PACE. But PACE got shackled with all manner of straitjacket regulations. So, for example, you can't offer a flexible menu of services in a PACE program. The client has to buy it all or nothing. So it's almost entirely limited to dual eligible patients, people who have both Medicare and Medicaid, because private assets, people look at this and say, I'm going to spend that kind of money, and it's only this set of services, and we didn't really need this and we didn't really need that, so I don't want to have to pay for it. But the PACE program can't do that. And PACE must evaluate people in their home setting. So you can't bring a person straight from a hospital into a PACE program. That means that lots of people sick enough to be in a PACE program instead go to nursing homes because they can't come home and enroll in a PACE program on the same day. So there's lots and lots of things like that that get in the way of PACE being as useful as it could be. But the idea of taking accountability for the person's housing, for their caregiving, for their being on the appropriate medications, those are all the right ideas. And so it's built a lot on kind of the thinking that went behind PACE, noticing that people needed something different, and that the socialization in the day center is a really important component, and that sort of getting out and about and seeing people can be an important component. But at some point, people are sick enough and disabled enough that it's really burdensome to get out to the center. Well, if you got to that point abruptly, say with a stroke, then the PACE programs don't want to take you because they aren't going to have a period of time in which they can keep their attendance at the day center up. And they have to meet a threshold on that in order to have their quality measures counted by CMS. So we just sort of straitjacketed PACE. And then there are lots and lots of other good ideas out there. The array is amazing. The GRACE program out of Indianapolis, the guided care that Hopkins put in place, patient-centered medical homes get part of the way toward what we're looking for. But there are a couple things that are regularly different. One is the real insistence upon a care plan. And now PACE does that, and even hospice does that. Home health does it with regard to whatever it is they're being sent in for, but mostly American medical care does not generate a real care plan. It's a catch-as-catch-can and sort of up to the family to make it coordinate. And then the other thing is this layer of local management where you would deliberately, it doesn't mean that there'd be a single provider or a single payer, but that there would be a coordinating body that would be noticing and deliberately noticing. They'd be running dashboards. They would be able to say, why is it that our rate of nursing home utilization is twice as much in Cincinnati as it is in Indianapolis? What's going on here? Is one of them too low or one of them too high? It's unlikely that these are just exactly right for their communities. And you could also monitor things over time. So I want to know the lifetime risk of getting a serious pressure ulcer if I grow old and die in Washington, D.C. And I want that lifetime risk to keep going down. Right now, we don't even have a way to monitor that. So we would have an entity that would be required to be monitoring and would be a place at which we would have the argument over whether the available funding should go into Service A or Service B, rather than it being just sort of up to some highly malfunctioning marketplace.
I think those are great points. One of the things that I liked about the opinion piece that you wrote in the Journal of the American Medical Association in JAMA was that you talked about, who specifically that governing body for a MediCaring ACO could be. And if I could quote your words back, you said that for now, the governance of a MediCaring ACO could be part of local government, a voluntary local coalition, or a home care or social services agency serving as the hub of a network of contracted long-term supports and services and healthcare service agencies and practitioners. And I think that's a really interesting concept, and I'm wondering, I assume that there would need to be, to your point, all of that data and, the data and feedback loop needs to be really seamless regardless of the governing body. Is that right?
Sure. Yep. We need to have a way to add up those care plans, no matter who is providing the monitoring. And we need it to be transparent. It needs to be on a website that people can go to and see.
I've got a couple questions here from the meeting chat box. The first is from Jade Gong. She says that this is a really exciting model for care redesign, and it seems like there might be challenges to achieve results in a really large community, and she's wondering whether you can give any insights into how community-wide changes, particularly I guess maybe for larger communities, how you could have a big impact and achieve change within the three-year window that you're talking about.
We're working with a couple of very large communities, and what matters probably even more is the degree to which there has been some history of collaboration and trust. It doesn't have to be that they aren't competitive. The service providers can be intensely competitive and still feel that they are working in the interests of whatever the community is. So, let's take, Peoria as an example. If in Peoria there were 5 health systems and 20 strong home care agencies and 20 strong hospices, they could all be most interested in doing one another in, but are also willing to cooperate on this population and probably on a couple others, like poor mothers. Let's not have handicapped children just because we never got around to cooperating on prenatal care. And there's some things that are just so much anchored in the community that I think that at least in well-functioning communities, people can find areas of cooperation, even if in other areas they're quite very much competing. I do think you have to be able to get the key decision makers effectively into a room. There is a size that just becomes unwieldy. So we are trying right now to work in a chunk of New York City that is a self-defined community where people know they're living in this community. And we'll see, is it still just such a complicated array of service providers that you can't ever quite get to the tipping point and do things differently there than you do in all the rest of the city? Or, is there the real possibility that, if this community says, no, actually, we are going to make sure that people can stay home as long as possible, we're going to encourage volunteer activities, we're going to mobilize services to the home, we are going to show you how to do it differently, even if there are a lot of small proportion providers. Can you get to the tipping point and change the pattern of care in a complicated area? Actually, in our initial work on care transitions, it has been hardest to work where there is one dominant hospital system, because that dominant hospital system assumes it is the be-all and end-all. And it is so hard to develop real equity around the table when one party has, a $75 million a year budget, and everybody else has, the crumbs that fall off the table, and their budgets start at a million and go down. It's actually better when you have two health systems that are kind of holding each other in check and creating the room for others to have a voice. So we'll see. We'll learn.
I do think that it's interesting. You'd mentioned some issues related to whether consolidation in different geographies is needed, and and at the same time, I think, to your point on sort of the hospital or health system end, it may be that market consolidation can be counterproductive to developing partnerships. So maybe there's some kind of a balance that's needed when we're thinking about sort of competition and,
in
market.
one community where we were working on this, there was something of a natural divide in just geographically. the hospital systems were dispersed enough that you could say, okay, so in general, we're going to try to have hospital A take care of this part, B take care of that part, C take care of that part. Now, an individual patient who gets, is in the A area but is madder than hops with the A providers can bring in a B or a C, but they're going to have a little higher copay. The system is going to be set up to assume geographic concentration, and you can violate that, but you're going to have to pay a little bit. So that's an interesting possibility. Or you have to have a reason to really not want to be served by the party that ordinarily would have your area. I think we're going to have to learn how to deal with the geographic concentration issue. We have been just utterly blind to it, but it just leaves way too much money on the table. You can't
I think you're right. Go ahead.
I say you can't get down to the efficiency we need without geographic concentration.
Mm-hmm. I think there is this tension, and it's not just for your model that there's this tension. I think that with ACOs in general, I think that this isn't, the antitrust issues kind of just rear their head. And it does make me wonder, just sort of thinking about all those regulatory issues that have been confronted by the shared savings program and, the pioneer ACOs, I guess. Do you think that those regulatory issues basically cover the waterfront of what's needed to be addressed in relation to your program, for MediCare?
The ACO endeavor with both, various Stark things and the antitrust issues, they become really serious because a part of the Articles of Faith of the ACO movement was to serve everybody in the population. So, it was meant to include commercial insurance, children, Medicaid, Medicaid only, and the elderly. The antitrust issues are very different if you have the management vested in an entity that is operating as a public trust and has some degree of, or an acceptable degree of transparency and working in the public interest. And the funding is essentially all public. I mean, there's private funding, but there's not other entities involved, like insurance companies and such. It's all Medicare and Medicaid. And, in some communities, a sizable proportion of veterans. But that's it. So frail elderly are a population where if you ever ended up being alleged to have an antitrust violation, they would ask first whether this was a dominant system in this geographic area that made it very difficult for others to enter the area, and the answer would be yes. You can have all kinds of different entities under this umbrella, but they're all under one umbrella, and it's going to be very hard to establish a second umbrella. So you'd lose on that point. But the second point is it contrary to the public interest? And you would win hands down there. You're reducing costs, monitoring quality, improving quality, and doing it all in public. And the antitrust hearing would, rupture in laughter. Well, of course, this is not contrary to the public interest.
Very interesting. I've got one more question from the meeting chat box. The question is there a place to go for creating an excellent care plan, and what all should be included?
I would love to talk to that person. We are working on a number of fronts trying to help define that. There are multiple definitions. There's a remarkable instrument being implemented in Minnesota that requires all manner of assessments and documentation of care plans, through to there's a pretty good set in PACE. I think PACE is still the sort of model, although it's at a very small scale. You really must deal with the finances, the direct care, the medical issues, transportation, and most importantly, what matters to this person and their family. And that's the heart of the care plan, is right there. But then exactly how to screen and get to know enough both to understand the current situation and to be able to help them understand what they're getting in the future with various choices. how burned out is this caregiver going to be? How much risk are you taking of bankruptcy? What are the medical outcomes of going home instead of going to rehab? We need a lot of work on being able to efficiently get an adequate assessment and care plan, and then to be able to inform that process with good information about likely outcomes. And there's a lot of work needing to be done there.
Absolutely. What a great question, and thank you for the answer. I'm going to ask you one more question. I know we're at 3:30, but because your model really integrates, so many aspects of care, not just the medical, not just, skilled nursing and therapy, but also the long-term care aspects. I mean, I know you spoke before the Long-Term Care Commission. I'm wondering if you can speak to sort of the political challenges there might be toward dissemination of a model like this, given the reluctance that our policymakers at a federal level have shown toward really confronting issues with long-term care.
I mean, it's just what the population demands. You don't make things more complicated than you have to serve the people correctly. If you're dealing with people who are double amputees, you better know a whole lot about wheelchairs and about prostheses, so if you're dealing with a population that has a whole lot of ADL dependency and is gradually getting worse or at least more disabled, then you really need to be able to have in the scope the long-term services and supports every bit as much as the medical care. If I'm taking care of my aunt with serious dementia, the medical care side is almost irrelevant. What really matters is managing the behavioral issues and having enough caregiving to endure the long, slow changes. We've sort of put it together backwards, assuming this is all medical, and it isn't. It's heavily non-medical, and we really need, and yet we put all of our money on the medical side. So we grudgingly, dish up a little bit of funding for institutional care, for in-home caregivers, the United States dishes up almost nothing for family caregiver support. Every other country does substantial support for family caregivers, and we don't. And that's the wrong balance for what this population needs. And I understand why we got there. We didn't have this population 50 years ago, or it was so tiny that it was possible for families to sort of rally and take care of their own. But now, most of us on this call are going to live to be frail, and we do not have the savings or the care system that is going to make that a very positive part of our lives. And we need to do that, and we need to do it soon, because if we don't do it soon, we are going to learn to walk away and to allow elderly ladies to, scrabble on the streets rather than be supported at home.
I want to thank you so much for your time and generosity in sharing your vision, Joanne. And